From Microbe TV, this is Infectious Disease Puscast, episode 49, recorded on February 28th, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. We are almost at 50 episodes.
That's pretty exciting.
Pretty cool.
Pretty exciting, yeah. With the success of Febrile, are you going to stay with us, Sara?
Yes. I'll be here.
Okay.
I have to keep up to date somehow.
I was just listening to Rash Decisions on my drive about today. No more comments because I want to give anything away.
Well, the real question is if I can keep the titles up. I feel like I'm probably starting to run low on clever titles, so people can send me ideas.
Okay, sounds good.
Well, Puscast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we? I will open up our viral section. Don't forget to listen to This Week in Virology or TWIV. The first paper I have is from the New England Journal. It's a quick report and update. HIV-1 remission after allogeneic hematopoietic cell transplantation. So this is an update on the results of the now 60-month or 5-year follow-up of a 63-year-old male who has remained HIV-free after undergoing a stem cell transplant for AML treatment from a donor who had a Delta 32 mutation, which causes a CCR5 deletion. And so that's been associated with resistance to HIV-1 infection. This patient is I feel like a lot of them are known by their locations. He's at City of Hope National Medical Center. And just to recap a little bit, the patient has a history of an HIV diagnosis from 31 years prior to their transplant, has remained undetectable from a viral load standpoint since 1997. And the HIV RNA levels have also remained undetectable post-transplant. So they interrupted his ART therapy 25 months after the transplant. The HIV viral load, as I mentioned, remained undetectable. His CD4 has been in the range of about 350 up to a little over 1,200. And so I included, there's a figure that shows the patient's course and his immunologic studies. And it's really cool. They show the HIV DNA that's initially detected in peripheral blood mononuclear cells before the transplant, but then becomes almost undetectable after transplant in those peripheral blood cells and in gut tissue. And testing for intact proviral DNA revealed a more than 2 log reduction in total proviruses, with no intact or total proviruses detected after the treatment interruption, meaning ART, I should say. So pretty cool. Patient remains in remission from both HIV and AML, and his blood and bone marrow reservoir sites have converted to full chimerism with the CCR5 Delta 32 donor cells.
Very exciting stuff.
Cool.
All right. The article, The Effects of Human Immunodeficiency Virus Type 1, HIV-1, Antigen Expanded Specific T-Cell Therapy, and Vorinostat on persistent HIV-1 infection in people with HIV on antiretroviral therapy. Phew, published in JID. This is potentially a very important discovery. And so for decades, we've struggled with the fact that HIV can integrate into the DNA of cells and stay latent for periods of time, essentially hidden from clearance by our immune cells. There's been efforts to try to reverse this latency. Prior to this publication, we knew that histone deacetylase inhibitor, Vorinostat, VOR, can reverse HIV type 1 latency in vivo and allow T cells to clear infected cells in vitro. We also can expand HIV-specific T cells ex vivo and safely administer these to people with HIV, people living with HIV on antiretroviral therapy. So here, 6 persons with HIV received low-dose infusions of the HIV-specific T cells with Vorinostat, and 3 patients with HIV received high-dose infusions of the HIV-specific T cells and varinostat. The frequency of persistent HIV by multiple assays included quantitative viral outgrowth assay of resting CD4 positive T cells measured before and after study therapy. Now, the treatment was safe and they detected some modest effect. Still lots of work to go, but encouraging.
Yeah, that's cool. So this next one, I didn't know anything about Alaska pox. So if you were like me, I'm going to share an update. It's been in the news because there was the first known fatal case reported in February. And so I have the link for the State of Alaska Epi Bulletin that shared some of the details. But Alaska pox virus is a recently discovered orthopox virus. It was first found in an adult living near Fairbanks, Alaska in 2015. Since then, there have been 7 reported infections to date. And previously, all of those cases were self-limited. Patients had a rash, maybe some lymphadenopathy, recovered well. But in mid-September of this past year, 2023, there was an elderly immunocompromised patient who initially had a red papule in his right axilla. It sounds like it didn't resolve despite getting, multiple antibiotic regimens, coming in seeking care, even ultimately had a punch biopsy done. But by November, he was hospitalized due to progression of what was thought to be cellulitis and drainage from that biopsy site. And then basically after some workup, so it sounds like it was initially reported as cowpox virus. If I was interpreting the report correctly, it sounds like from a Carius test. And then samples were ultimately sent to the Alaska State Public Health Lab and the CDC, who later confirmed Alaska pox. They tried treatment with IV tecovirimat, IV vaccinia immunoglobulin, and oral brincidofovir. It sounds like maybe there was some improvement, but he did ultimately die in January. So previously, all those cases I mentioned were also in the same general area. So this was not only the first hospitalized case, but represented a different location several hundred miles away from those. I also learned that the viable virus has been isolated from a red-backed vole and one shrew. And I guess that animal, the vole, has a pretty wide geographic range, not just including Alaska, but to Canada and Russia and China and Scandinavia. So potentially could be seeing more genetically distinct Alaska pox viruses in the future.
All right. Our listeners may not know, but historically, human metapneumovirus was one of my favorite respiratory viruses. Now, historically, when the cases would start to appear, I would know with more confidence than that instilled by a rodent rising to look for its shadow that spring and sailing season were on its way. It's a little reference to the groundhog that we reference here in the United States for our weather predictions. But I've worried about the neglect and lack of respect for this poor virus, so let me share the following article. The burden of HMPV, human metapneumovirus, and influenza-associated hospitalizations in adults in New Zealand, 2012 through 2015, published in JID. So here the investigators compared the population-based incidence, seasonality, and clinical characteristics of these human metapneumovirus and influenza among adults aged 20 years and over with acute respiratory infection hospitalizations in Auckland, New Zealand during the 2012 through 2015 in the Southern Hemisphere Influenza Vaccine Effectiveness Research and Surveillance, I love this, the Shivers Project.
So good. If only it's spelled Rigers.
All right, so Shivers Me Timber Project. Of the 14,139 acute respiratory infection hospitalizations, 4.3% tested positive for human metapneumovirus, 19.1% tested positive for flu. Crude rates, 9.8 for HMPV and 47.6 were estimated for every 100,000 adult residents annually. Highest rates for both viruses were in those aged 80 and older, of Maori or Pacific ethnicity, or living in low socioeconomic status areas. The HMPV infections were actually more common than influenza in those with chronic medical conditions. Although human metapneumovirus infections accounted for fewer hospitalizations than influenza in adults aged 20 years and older, the human metapneumovirus-associated acute respiratory infection hospitalization rates were higher than influenza in older adults, Maori, and Pacific people, and those of low socioeconomic status.
You know, I will our viral section, we mentioned multiple rodents.
This is
I guess they're the star of today's episode.
All right, moving into bacterial. Be sure to listen to This Week in Microbiology. I like this article. The article, Length of Antibiotic Therapy Among Adults Hospitalized with Uncomplicated Community-Acquired Pneumonia 2013 through 2020, was published in Infection Control and Hospital Epidemiology. I actually quoted this study in rounds yesterday. So any article that is going to get introduced during my teaching rounds. So here the investigators conducted a retrospective cohort study among adults with a primary diagnosis of bacterial or unspecified pneumonia in MarketScan and the Centers for Medicare and Medicaid Services database. They included patients with length of stay of 2 to 10 days discharged home with self-care and not rehospitalized in the 3 days following discharge. They examined trends from 2013 to 2020 in patients with total LOT, length of therapy of greater than 7 days, which was considered an indicator of likely excessive length of therapy. Now, just a reminder to our listeners, current clinical practice guidelines recommend that antibiotic therapy be continued until the patient achieves clinical stability and for no less than a total of 5 days. So this should be easy. Most providers follow the guidelines, so most of the time we should be all good. Even got a couple extra days if you want to go out to 7 days, a shift from the carpal to the Constantine duration. Now, there were 44,976 and 400,928 uncomplicated CAP hospitalizations among patients in the 18 to 64 years of age, and then that larger number in those 65 years of age and older. From 2013 to 2020, the proportion of patients with total length of therapy greater than 7 days decreased by 25%. But are you ready? From a high of 68% down to 51% in those aged 18 to 64, and by 27% from 68 to 50% among patients aged 65 years of age or older. Now, although it seemed that excessive length of therapy for uncomplicated CAP patients decreased, the proportion of patients with length of therapy greater than 7 days still exceeded 50%. So I want to point out that this variation from the guidelines is not innocuous, as a recent meta-analysis highlighted that each additional day of antibiotic therapy, unnecessary antibiotic therapy, is associated with a 4% increased odds of experiencing an adverse event. I also want to highlight that this may be hard to control, as many patients were discharged on these extended durations, even if they kept that duration of 5 to 7 days while in the hospital. So really a challenge for our antimicrobial stewards to somehow catch this so that people are not sent out with another 5 to 7 days of antibiotics that are not necessary and potentially harmful.
Wow. Speaking of another stewardship challenge, I pulled a paper from JAMA Dermatology entitled Efficacy and Durability of IV Ertapenem Therapy for Recalcitrant Hidradenitis Suppurativa. Or I'm probably just going to say HS, it's a little bit easier. I'm going to start with the side because I am sure many ID docs who are listening have encountered the lure of using IV ertapenem for 6 weeks or sometimes longer for HS, which is based on case reports and some smaller retrospective studies in the derm literature, and it actually is noted as a recommendation in the North American treatment guidelines. So that's where it comes from. If you have not encountered patients with HS, it's a pretty terrible follicular skin disorder. that often is complicated by overlying bacterial colonization, and management generally ends up being some mixture of topical, oral, and or IV antibiotics and immunomodulation. So here, the authors identified 98 patients. So those that were included had advanced HS, which is based on a HS Physician Global Assessment Scale. And they were included if they had, quote, suboptimal response to topical or oral antibiotics, anti-androgen, or anti-inflammatory therapies, which could include adalimumab and infliximab. This was retrospective. It's a medical record review. And they concluded that IV ertapenem for an average of 13 weeks was associated with improvement in clinical and inflammatory markers, as well as improved patient satisfaction. And I usually don't pick on articles, but I am very skeptical and have lots of thoughts because I guess I just don't believe that ertapenem is this unique antibiotic that magically just works for HS. And I think, for example, the conclusion that leukocytes, CRP, and IL-6 were improved after ertapenem is challenging. These are not validated markers for HS disease. And if you actually look at the numbers, the white blood cell counts went from 11 to 10-ish, which I don't know that I would have necessarily considered that clinically significant. The authors do acknowledge, I pulled a quote, the definite mechanism of ertapenem efficacy in HS remains elusive. And they do comment on how significantly improved HS outcomes in absence of cultivable, that's a challenging word for me to say, bacterial growth appear paradoxical. A possible mechanism of IV ertapenem may involve its effect on uncultivable bacteria that escape detection in aerobic and anaerobic cultures, rendering false negative results. At this time, we are unable to validate this hypothesis with conventional culture-based methods. This suggests that microbial cultures offer a limited form of guidance in clinical decision-making. So I didn't say this, but the paper included basically swabs that were bacterial cultures from actively draining sites. And the other thing that bothered me a little bit is they commented on how several species, such as Enterococcus, did not clear by the end of therapy with ertapenem, which I do not think is terribly surprising. They also reported that adverse events were uncommon, but there were 9%, so 9 patients who needed a PICC line replacement, 7% who had a dermatitis related to their PICC line dressing, and 2 patients had a PICC line associated infection. Their other sort of positive outcome is they called these patients and asked, were you happy with your therapy, and would you be willing to go through the process again of receiving IV ertapenem? And 80% said, yes, we were happy with it and would go through this again. So, I think often we are not necessarily involved in these cases, meaning ID. And I think it's because a lot of folks in ID would say no or try to discuss the argument for antimicrobial stewardship. But, to be less pessimistic, wouldn't it be nice and fruitful to have an ID derm combined discussion or guideline? And if that exists, someone can send it to me. But as far as I know, it doesn't exist. So anyways, I haven't come up, I haven't had it come up recently, but I have definitely encountered it, and it pops up every once in a while. I don't know about you, Daniel.
Yeah, I may have carved a little niche here because these are challenging patients that get sort of turfed around, and it really is a very, really, I'd say horrible, disabling disease, really affecting people's ability to enjoy life. And so, we have a great specialty center out here, actually at the Long Island Jewish Medical Center. And I've managed some of these patients in concert with them. And, sometimes surgeons are involved. It is very challenging. But I'm a little worried about 13 weeks of ertapenem in the management.
Yeah.
So,
or I think in my heart, it's not that I think that these patients don't at times benefit from antibiotics. I guess the question is, this idea that like IV ertapenem is the one that beats them all. I don't know that I can conceptually understand that when they could be on other regimens.
Yeah.
Although, if you had to put someone on an IV, I can see why someone would like Ertapenem as a once-a-day med.
Yeah, 30 minutes once a day,
Yeah.
broad coverage. Yeah, but
yeah.
I'm not endorsing that.
Yeah, Puscast is officially not endorsing prolonged
Yes,
courses of IV
because
Ertapenem.
you know what might happen, and that brings us right into the article AGA Clinical Practice Guidelines of Fecal Microbiota-Based Therapies for Selected Gastrointestinal Diseases, published in Gastroenterology. So of the nearly 500,000 Americans who experience CDI each year, some of them after 13 weeks of Ertapenem perhaps, an estimated 35% have recurrent infections, and the risk of subsequent recurrence goes up with each case. That's Clostridium difficile infection for the CDI three-letter acronym. The FDA has approved 2 products that deliver fecal microbiota live organisms. This is Rebiota via enema and fecal microbiota spores by VOWST. You get that via oral capsules. So the guidelines suggest that use of the FMT, the fecal microbiota-based therapies, including conventional, that's where they put the poo in a blender, Rebiota and VOWST in immunocompetent adults with recurrent CDI after the second recurrence, or in select patients with high risk of either recurrent CDI or a morbid CDI recurrence. Of note, I think it's important, severely immunocompromised adults, such as patients who have neutropenia or who have received a bone marrow transplant, are excluded from this recommendation. But pretty striking to see this recommendation.
I pulled a paper from the New England Journal, Cefepime taniborbactam, hopefully that is correct, and complicated UTI. So Cefepime taniborbactam is a new beta-lactam beta-lactamase inhibitor. The taniborbactam is a broad-spectrum beta-lactamase inhibitor. It's capable of inhibiting Ambler class A through D enzymes, so restoring activity of cefepime against multi-drug resistant gram-negatives such as carbapenem-resistant Enterobacterales and Pseudomonas. This was a phase 3 double-blind randomized trial of hospitalized adults with complicated UTI, including pyelonephritis, the CERTAIN-1 study. Patients are randomized 2-to-1 to receive the IV cefepime taniborbactam or meropenem for 7 days, which could be extended up to 14 days if there was bacteremia present. The primary outcome was a composite of microbiologic and clinical success in the microbiologic intention to treat population. So this ended up including 436 patients. The breakdown within that were 58% who had complicated UTI, 42% with acute pyelonephritis, and 13% with bacteremia. The composite success occurred in 207 of 293 patients, or 71% in the cefepime taniborbactam group, compared to 58% in the meropenem group. So this was superior with a treatment difference of 12.6 percentage points. The differences in response were sustained at the later follow-up on trial days 28 to 35. The adverse events that were present in the trial occurred in 35% of those in the cefepime taniborbactam group and 29% in the meropenem group. Discontinuation rates were 3% for the newer drug and 1% for Miro. I did see, so this is exciting, another drug. I saw that there was some sort of manufacturing issue which led to the FDA rejection. So I don't know what the future looks like and how that timeline would look, but that's the newest update. I think that was just from earlier this week.
Yeah, I just saw that earlier this week, and it's always, you get all excited. And then I think that's a realization. It's not just important to have effective molecules, but you need to have effective, safe production.
Yeah.
All right. Well, it should not surprise anyone that we are seeing reduced vancomycin susceptibility in C. diff. As I share the article, reduced vancomycin susceptibility in C. diff is associated with lower rates of initial cure and sustained clinical responses, published in CID. So these results come from a multi-center cohort study, including adults with C. diff infection treated with oral vancomycin 2016 through 2021. And they report that a high proportion, 34% of the C. diff isolates exhibited reduced vancomycin susceptibility. And the reduced vancomycin susceptibility was associated with lower 30-day sustained clinical responses, and that was 76% versus 86% in the vancomycin susceptible strains.
I have something from CID, the comparative effectiveness of perioperative antibiotic regimens to prevent surgical site infections in pediatric liver transplant recipients. This was a cool study. It was a retrospective observational look at pediatric liver transplant patients using a data set that it seems like they basically combined info from the FIS database and UNOS information to look at the antibiotics received within 24 hours of liver transplant. They classified these in a range of category 1, meaning cefazolin as sort of the least broad, up to a category 6 that included carbapenems, and then there's grades in between there. The primary outcome was presence or absence of surgical site infection in the index admission. Of about 2,600 liver transplant recipients, 284 or 11% met surgical site infection criteria. Surgical site infection rates were higher in the younger subcohort, so children under 1. That rate was 16%. The antibiotics from category 5, it seemed like were most used. So just to give people a perspective, that's a combo of Cefepime-Metro, maybe Piptazo, or something along those lines. But there was some wide variation in prophylaxis. The most important take home is that the author's adjusted analysis didn't show a protective benefit of being on the broader spectrum prophylaxis, those higher categories. So we know there's no consensus on exactly which prophylaxis to provide these patients, but this paper would suggest that we probably could use narrower regimens without an increase in surgical site infection. So, cool study.
All right, moving us into fungal. In open form infectious disease, we have the article Histoplasmosis Beyond HIV, Clinical Characteristics and Outcomes in Non-HIV Population. So these are results of a retrospective study comparing non-HIV immunosuppressed patients with an historical cohort of HIV and histo. They included 199 patients with proven or probable histoplasmosis, of which 25% were non-HIV. Diabetes, chronic kidney disease, hematologic neoplasms, rheumatological disease, transplants were more frequent among the non-HIV patients. Death after diagnosis occurred in 44% of the patients. So 44% of immunocompromised non-HIV patients died within the first 6-week period following their diagnosis. And they conclude by suggesting that a high suspicion index for histo should be kept in immunosuppressed patients.
That's a really high percentage. I have another fungal paper from OFID, Combination Antifungal Therapy for Invasive Mucormycosis in Immunocompromised Hosts, a Single Center Experience. So a group of authors from Stanford took a look at a contemporary cohort of immunocompromised adults, so hematologic malignancy, stem cell transplant, solid organ transplant. These are patients from 2009 to 2022 who met criteria for proven or probable invasive mucor, and they found no difference in 6-week mortality with upfront or salvage combination therapy compared to monotherapy. The exclusion criteria included patients who died within 72 hours of diagnosis and or those who were co-infected with Scedosporium or Lamentaspora. And so just to I think a lot of these studies are so heterogeneous to describe what they use. Upfront combo therapy was defined as 2 active antifungals within the first 7 days after diagnosis and use of those 2 drugs for at least 3 days. So salvage combination therapy was that same definition, but using the combo after the first 7 days. and then, of course, monotherapy. Most patients had hematologic malignancy. That was 78%. 62% had pulmonary disease, and half of the group had infection with rhizopus as their organism. So 24 or 29% of patients received monotherapy, 54% received the upfront combination therapy, and 17% received salvage combination therapy. The regimens are not totally clear. It seems like it was mostly liposomal amphotericin. Typically, it seems like at a dose of 5 mg per kg with POSA or isavuconazole. Overall, the 6-week mortality was 31%. They used multiple logistic regression and found no difference in the odds of mortality with the upfront, so odds ratio 1.4, and salvage odds ratio 2.15 therapy. And they actually included and looked at whether surgical intervention or neutropenia had an impact on mortality, and at least in their study did not find that there was a difference. I think, to be honest, this study, I suspect people are going to be unlikely to change their decision-making on whether to provide double coverage, meaning I think even though these trials and data are out there that it's not clear that combination therapy helps, but there's this sense that we are doing all we can by adding agents. And I suspect that in the case of a very sick patient, people, I don't know that this would sway them the other way if they feel strongly about doing combination therapy, but who knows? We'll see. And hopefully we'll have a better understanding of that at some point. I feel like I sometimes do, but almost more in the sense that they're on Ambisome and I am planning to get them on an azole and I'm waiting for their azole to get therapeutic. But I think less so that I'm trying to have them on dual therapy, if that jives.
I think it's hard when the mortality is so high, right?
Yeah.
Then when they die, you feel like, oh, if I'd only done two drugs. Yeah. All right, moving us into parasitic. Be sure to listen to This Week in Parasitism. The article, Asymptomatic Low-Density Plasmodium falciparum Infections, Parasites Under the Host's Immune Radar, was recently published in JID. And I think the main reason I included this paper was to remind people, or perhaps acquaint them with the concept of asymptomatic P. falciparum parasitemia. And just a little bit of discussion, and I do recommend people spend a little time looking at this. There's this concern, right, that someone in an endemic region has a P. falciparum parasitemia, and then you need to distinguish, are they sick with P. falciparum or are they sick because of P. falciparum? And then there's this other idea that low level of parasitemia is actually somehow maintaining their protection against P. falciparum. So important concepts to be acquainted with, and just to remind people that, yes, you can have really asymptomatic malaria parasitemia. All right, and still on malaria, hitting it heavy this time. There'll be a miscellaneous paper too, by the way. But the article, Have You Heard the News? Artemether lumefantrine is now recommended for all, in capitals, uncomplicated malaria in the United States, including in pregnancy, published in CID. Now, until recently, only chloroquine, mefloquine, or quinine plus clindamycin were recommended for treatment of uncomplicated malaria in the first trimester. In late November 2022, following a review of new evidence demonstrating that artemether lumefantrine is effective and safe in the treatment of malaria in early pregnancy, the WHO endorsed artemether lumefantrine for treatment of uncomplicated malaria during all trimesters of pregnancy. And now, just shortly thereafter, let's see, December, January, February, that's 3 plus 12. 15 months later, the CDC has updated its guidance for the treatment of uncomplicated malaria during pregnancy, aligning with the current WHO guidance. And so this is a great and perhaps a reminder that if you only see or only treat a handful of malaria cases, have the humility to reach out to one of your colleagues with expertise in this area. It's a moving field, and find someone who's perhaps treated hundreds of cases and get them to sort of help you out with the guidance.
Yeah. Always good advice. And then for our miscellaneous section, I pulled from CID, minimizing low-value, uncompensated work in academic infectious diseases, a 6-step program. This was a really nice article, gives some strategies to maximize our higher value job functions while minimizing low value tasks. There are lots of good quotes in here. I just pulled one that I enjoyed. A quote, "In fact, excessive email traffic and clutter may make professors stupid," as further explored by Newport in a Chronicle of Higher Education article, where email is described as a kind of digital water torture for the scholar struggling to think without interruption. So you can read the article for more, but I figured I would mention the 6 steps to encourage people and hopefully spark their interest to go read it. Step 1, define your high-value top priorities and take inventory of uncompensated work and distractors. Step 2, budget no more than 20% of overall effort for uncompensated work, especially if it's low value. Step 3, protect and focus your non-clinical or uncompensated time. Step 4, clinical care, minimizing electronic distractions and trying to leverage support systems to maximize your focus. 5, prioritize an individual response to uncompensated work while honoring the group dynamic as a team player. And lastly, step 6, call your sponsor prior to taking on additional work. Appraise this using the value versus compensation matrix.
So I was thinking the 6-step program was like a nod to the 12-step program of Alcoholics Anonymous, and I particularly when they mentioned calling your sponsor.
Yeah.
Should I be doing this?
Yeah.
I'm being offered additional work. Please help. But no, I think that this is tremendous. I think academic infectious disease in general, is one of the fields where we do the most uncompensated labor. We don't really, I think, appreciate our value. So, I think this is really an important article. Maybe they should make this part. This should be on the boards. What are the 6 steps?
Just do some PSAs. Just have them running all the time.
All right. We have the research letter, Detection of Invasive Anopheles stevensii mosquitoes through molecular surveillance, Ghana, recently published in Emerging Infectious Diseases. So for those of our listeners that travel or do travel medical consultations, this is actually a significant concern. In general, malaria is a rural problem with limited issues for those living in or visiting urban centers. But this is changing. The ability of the Anopheles stevensii mosquitoes to breed in artificial containers enables them to thrive in urban areas, setting them apart from other major malarial vectors. So this species can transmit the P. falciparum, the P. vivax protozoan. Although malaria is, as we mentioned, widely a rural disease, transmission in urban areas is rising and can rise with the establishment of the Anopheles stevensii mosquitoes in these urban areas, putting millions of persons at risk for malaria. Now, over the past decade, this has been happening. The Anopheles stevensii mosquitoes have been expanding in range and have now been documented in several countries in Africa. And here, the authors conducted routine entomological surveillance in 8 sites within the city of Accra, Ghana, during January 2022 through July 2022. And they found these mosquito in larval samples from urban areas in Accra, Ghana, specifically the suburbs of Tuba, Dansoman, and Nima. And they actually have a nice figure where you can see where Ghana is, Western Africa, and then you can see where Accra is, the greater Accra area, right there on the coast, and where these different areas are. So really impacting travel advice and actually impacting things to think about. When you go to an urban area, you are now starting in certain areas to have to be concerned about malaria.
Well, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, and on your favorite pod catcher. We love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv. If you like what we do or want us to just keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or parasiteswithoutborders.com. Click on the donate button.
I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism, This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.